So, good evening to everyone. I'm Dr. Onkar Swami on behalf of Emcure Pharmaceuticals Limited. Welcome you all in this another exciting case studies or live in box cases with no thrombosis. I'm very pride, privilege, and honor to tell you this is our 37th module. Every fortnightly since last 1.5 years, we are conducting these sessions, and we have conducted almost 37 modules and three cases in each module, 6 cases in month. So all this credit goes to our faculty, all this credit goes to our speakers for these things, and it's my pride, privilege, and honor to welcome our course director, Dr. M.S. Hiremat sir. Sir's keen interest made this. So, as we know, sir is a director at Cath Lab at Ruby Hall Clinic, Pune. Sir was a past president of CSI 2017, program chair of CSI conference in 2016. Sir has been a convener for the National Interventional Council of India of CSI from 2004 to 2006. Sir has performed live angioplasty courses to many national and global interventional conferences and has proctored many interventional cardiologists and given live courses across the globe. Sir has a great experience in peripheral angioplasty, including legs, carotid, and iliacs. And Sir has been participated in many groundbreaking trials. Welcome you, sir. Thank you very much for being a part of this program. Now I welcome our moderator, Dr. Jabir Abdul Kuti, sir. Sir is Senior Consultant and Director of Clinical Research of Cardiology at Lisi Hospital, Cochin. He has more than 2 decades of experience in cardiology practice and well-recognized cardiologist and a faculty for national and international conference, expert in managing complex heart disease. And sir has been well-recognized by the peers, colleagues, and the patients. And sir's area of interest is coronary intervention and heart failure. Sir will be joining shortly. We have Dr. A. Srinivas Kumar, sir, as a course moderator. Sir is a co-director of cardiology and clinical research at Apollo Hospital, at Apollo Health City, Hyderabad, and professor of medicine at Apollo IMSR, Jubilee Hills, Hyderabad. Sir has been a chairman of a FACTS Foundation and founder director of TCT India for South Asia Conference. And sir has a special interest in TAVI, intercoronary imagings, and sir has been a past president of APCSI and past chairman of CSI NIC. So thank you very much, sir. Sir will be also joining soon. So we have today guest moderator, Dr. Girish Navasundi, sir. Sir is the director at Cath Lab and senior interventional cardiologist at Apollo Hospital, Bangalore. Sir has almost 2 decades of experience in the field of cardiology. And sir has been a first cardiologist to implant a bioresorbable scaffold stent in the private sector in Karnataka, and also first to implant a MRI conditional AICD in Karnataka. Sir has a special expertise in a complex coronary angioplasty, stenting to CTO, and 100% blocked blood pipes, and rotablation for severely calcified arteries, bifurcation angioplasty, and left main angioplasty. Sir has a very keen interest in treatment of disease of aorta, aortic aneurysm, and aortic dissection. We welcome you, sir, for this program. This is our 37th module, and every fortnightly we discuss 3 cases. I welcome our faculty or speaker for the night, Dr. Kaustubh Partani. He is a consultant interventional cardiologist at Partani Hospital, Parbhani. He will be presenting a case of long segment CTO with perforation. Our second speaker for the day is Dr. Shravan CPS. He is an assistant professor and assistant professor of vascular surgery at Sri Jayadeva Institute of Cardiology Sciences and Research, and also a consultant vascular and endovascular surgeon at Trinity Heart Foundation and Trinity Central Hospital, Bangalore. Sir will be presenting a complex rotagrade peripheral angioplasty. Now I welcome our faculty for the day, Dr. Samir Malhotra. He's a director of interventional cardiology at Primus Super Specialty Hospital, Delhi. He will be presenting nightmare in a cath lab. I think with this short introduction, let's move to our faculty, our course director, Dr. Hiremat sir, for the opening remark, and then we can start with the cases.
Yeah, I think good evening, everybody. You are able to hear me?
Yes, sir.
Okay. I think as Dr. Onkar mentioned, this is our 37th meeting. And a lot of credit must go to Onkar and his team, who have made special efforts to get connected with some of the top working people and got them to this forum. I must confess that the way we started and where we are, it's a huge difference. And I think many of us are learning a lot of new things through the interaction, through the kind of cases that are being presented. So we start with Dr. Kaustubh today, or?
Yes, sir. Yes, sir.
Okay, Dr. Kaustubh is from Parbhani.
Yes, sir.
And Kaustubh, over to you for today's presentation.
Thank you, sir. Good evening, everyone, and thank you, Emcure, for giving me this opportunity. And good evening, Remark, sir. Today, I'm going to present one nightmare case in cath lab, which was of long segment CTO with perforation.
Dr. Kaustubh, can you make the full screen? We are
Yes, I have made full screen.
No, we are not able to see full screen. So you can just unshare once again and share.
Stop share.
What about Dr. Jabir? Is he joined us or
Yes,
not?
yes, sir.
Yes, yes, sir. I'm here, very much here.
Okay.
How are you?
So we are good.
Is it a very
Sir,
beautiful weather in Pune now?
What is it?
The weather in Pune, it may be very good now, end of February.
Actually, we are getting into warmer
Oh, warmer.
afternoons now, last 2-3 days.
Otherwise,
But yes, what you're saying is quite true, that it's been a nice winter this time.
So Dr. Kaustubh, what I suggest, till it is not showing as a full mode, you can make first full mode and then share the slide.
I have made full mode now. Still, you can't see.
No, because there was something called as resume screen show that was not coming. So you can make first full. Now you can make a full screen and then share, unshare and share. Somehow we are not able to see. This slide will not move. You will speak, but will not move. That's what our experience is.
Okay.
Yeah, now it's loading.
Can you see full screen?
It's loading. Still, we can see the. It's loading. Not yet full screen. No, sir. We can't.
Can we go to the next case and come back for Dr. Kaustubh's case again?
Can be possible, sir. Can we do,
Yeah.
sir, Dr.
Yes,
Kaustubh?
yes, sure, sir. Please
Okay.
go ahead.
So, Dr. Shravan, would you like to present?
Yeah, no problem. Let me just start my screen show. Is my
Yes.
short screen visible? Is my PPT
Yes.
visible?
Yes, sir. Yes.
All right, great. So, good evening to everybody. A very good evening to the chairperson and the moderators of this session, all my senior colleagues. It is a pleasure to present a complex case in front of you. I'm Dr. Shravan. I'm a vascular surgeon by training. I'm an assistant professor in the Jayadeva Institute, and of course, my outside work is at Trinity Hospital in Bangalore. So, being a vascular surgeon, fortunately, I have the opportunity to work at all vascular beds. Of course, I leave the brain and the heart to the experts. You know, the session is full of the heart experts, but fortunately, I can work with the other parts of the body. So complex CTO cases are like all of Tom Cruise's stunts. It looks scary, you think, how does he do it? But
Okay.
with a lot of planning and of course a lot of gut-wrenching moments, and you can always get a good result. So similar to that, I had a 70-year-old male who was a community ambulant person, an ex-smoker, diabetic, hypertensive, with a history of LED stenting done 5 years back, very poor heart function, ejection fraction of 25%, and repeated admissions for cardiac failure. He had multiple injuries to his right toes while he was trying to cut his nails, classical history which a lot of our vascular patients tell us, which turned into non-healing areas, gradually changed into gangrene, and the first toe started to get infected. Of course, severe wrist pain, very commonly seen in our patients, no sleep at all, and the patient pleading to me, "Doctor, please cut my leg." So I got a CT angiogram done. Right side is the index limb. Good flow till the distal SFA, but the popliteal has a CTO, and the reformed peroneal looks good. TPT and LTA looks calcified, and the entire posterior tibia is gone. Plantars again look good, and of course the DP is also seen. So with this picture in mind, I took an ultrasound-guided antegrade femoral access, went down, and similar to the CT angiogram, the initial angiogram confirmed that there's a very beautiful genicular collateral giving rise to the peroneal, which again in turns gives rise to a good DPA and a very good plantar arch. Went in with a 035 Tiramo glide wire and hoping that at least a selective shot of the anterior tibial would show some form of distal parts of the anterior tibial open, but unfortunately just few collaterals. Of course, I still did try, but the wire just refused to go through into the anterior tibial. So ballooned the popliteal a little, took a 4 balloon just to get some space, started to balloon it. And then again was able to push the balloon into the anterior tibial just to open up the ostial region, hoping that at least that would give me some leeway to push the more hardware downstairs. But this was the maximum I could get after 1 to 1.5 hours of trying from the antegrade approach. Neither could I progress into the anterior tibial more than this, nor into the tibioperoneal trunk. Not just with the Tiramo and the standard multi-catheter, but I also took a CXI. I also used a V18, used a WIN wire also, and of course tried a coronary Gaia also. But I couldn't pass through the TPT occlusion, and there was no progression from the anterior tibial also. And being almost 1.5 hours, now this was the check angio. Almost square one, just a trickle of flow into the open, the angioplasty popliteal segment. But at least the good collateral genicular flow is there, and the peroneal is well kept open. So at this point of time, I decided to go retrograde, and I, with an ultrasound, scanned the dorsalis pedis and the common plantar. But circumferential calcium, I couldn't even see the lumen at all. Very badly calcified vessel, which is a clear contraindication to try any retrograde access, because that's your good outflow, and you may stick up some of the plaque into the lumen and you may ruin that outflow. So decided to go with a retrograde peroneal access because not much calcium, good sized vessel, and open throughout the way. So with the fluoro shot from above to guide my needle position, gradually entered into the peroneal artery. And my go-to hardware for retrograde is always a V18 and a CXI catheter. Initially thought, why am I not in the calcium? Then I realized, of course, that's an overlap of the anterior tibial and the peroneal, and was right into the peroneal artery. Gradually worked my way upstairs just to check whether I am in the peroneal. Took a shot from above again, and yes, I was in the peroneal. Sometimes you feel, yes, the job is done, let's cross and finish it. But again, that's when a small 1 centimeter of calcified segment in the tibioperoneal trunk says, no, I'm not going to allow you to finish the case. You could see that the tip between the catheter from top and the CXI catheter, the support catheter from bottom, is just a centimeter of CTO. Trying to push my V18, but it just wouldn't budge. This is a angio from the CXI catheter, and you can see that the distance is not much. Tried from above and below combined. And of course, we do remember that the angiogram is a 2D view, even though this looks like the wire from above and below are giving a handshake, but we are in two different planes. So try to break open the plaque from above, trying to just have a small break in the plaque, which would help my wire go from below. But that didn't work. So I took it one more step, inflated a balloon in that region in the tibioperineal trunk because I had slight leeway, and tried to push the wire into the balloon, trying to perforate the balloon so that my wire goes inside the balloon and then I can pull it back up into the true lumen. But again, I was stuck in the subintimal plane, and the balloon and the wire from retrograde approach were in different planes. After that, again, I thought, okay, let's see how much we've gone through. And of course, there is some progress from the retrograde aspect, but I could see there's a slight lighting up of the true lumen above, but none of my wires were passing through. So tried to do a cart, reverse cart, took two different balloons, 1.5 and a 2 balloon from above and below, trying to split open the plaque. Trying in two different positions so that the plaque loosens up a little. But again, no much progression. And at this point of time, I was thinking, okay, maybe this is a time to stop. Let's convince the family for a high-risk peroneal bypass and let's get done with it. So then I was like, okay, let's give a last try. And from above, took a V18 wire and tried to push it through that plaque, and finally, yes, I was able to pass through from above. So I did get a little a pathway by breaking that plaque from below. Confirm my position that I crossed the TPT into the peroneal, and that's a happy moment across all the staff members of the cath lab. First step, broke open the calcified segment. You could see that tight waist in the region of the tibioperoneal trunk. And once that was done, this was the angiogram. Definitely confirm my position in the true lumen. Of course, the speed of the contrast is very slow because you have a spiral dissection and some thrombus in the popliteal, and still there's a huge chunk of plaque sitting in the tibioperoneal trunk. But at least I know that I'm in the right direction right now. Following that, first I wanted to remove my retrograde axis. So I took a 3 mm balloon, inflated for a good 3 minutes at where I punctured my peroneal so that a good hemostasis is achieved. After that, rechecked how things are above. Flow is still less. So I wanted to plasty the whole segment. You can see that the contrast is just having so much difficult to come down all the way. So balloon the whole segment again. The trouble seemed to be that TPT area again and again. So gradually ballooned it, a 3 balloon, and then with a 4 balloon. And anyway, I wanted to put in a stent because there's a bad spiral dissection in the popliteal region. So I started preparing the bed for the stent, took a 6 mm balloon because I wanted to use a 5.5 supera. Plastied the entire bed, and just to check the pre-stenting angio. Yes, there is some flow, but of course not great flow again. Checked my measurements for the stent, and then I took a 5.5 into a 150 supera. I feel supera is the most difficult stent to deploy. Of course, with practice, everything becomes easy. But compared to the other self-expanding stents, you need a lot of control and patience, I feel, to deploy a supera because the diamonds have to be just beautifully perfect. So coming up, I saw to that there's some stacking of the stent at the area where it's very calcified, so that the radial force is more in that region, releasing the top end of the stent. Not much elongation or decrease in length. And this is the check angio after the stenting. There's a good flow across the stented segment. The dissection is pushed away. But again, we could see that the flow is slow and not with a rapid pace, which what you would like. And again, another good spiral dissection in the tibioperoneal trunk. So decided to drop in coronary DES, a 2.75 into 38 Promus Premier from Boston. This was the first one extending from the tibioperoneal trunk into the proximal peroneal artery. And then another one with a good overlap from the tibioperoneal trunk to the popliteal artery. This was a 3 into 38. And then flat up the proximal end so that there's some kind of opposition between the two stents above. And this is the final check angio. You can see that the flow is very nice, rapid, going down, your outflow is maintained. You can see the common plantars lighting up. And the final DSA is showing that there's a very good flow in the dorsalis pedis and the plantar system all the way to the forefoot. So post procedure, I put him on 75 milligram of clopidogrel, 20 milligram of rivaroxaban, because I wanted to give a full dose anticoagulation for him, and high dose statin of 40 milligram atorvastatin. And this case was done in November, and by now the wounds are all completely healed. Thank you.
Thank you, Dr. Shravan. I think legs I really like to do, and is the time that is spent in the cath lab. So as you mentioned, the whole procedure must have taken about 3 hours or maybe longer.
3 years, just shy of 3 years.
Yes. So, but I think you showed tremendous patience, and that is what I always tell my staff when I'm doing a peripheral case. Honestly, I love doing peripheral cases, and Dr. Jabir also likes to do peripheral. Correct?
We would like to do peripherals, but as you rightly pointed out, this infrapopliteal disease, like this case, which Dr. Sharavanan did a fantastic job. He could save the limb. That is much more rewarding than sometimes saving the life of a patient. The losing a limb is a real trauma, and it really hurts the patient. And if you could save the limb, it's a great service to the mankind. But the time, 3.5 hours, 4 hours, and the stress you are taking, the adrenaline surging, you had a lot of difficulties going from the antegrade, then the retrograde, the punctures, then multiple stents. But finally, you could save the limb. That is the most important thing at the end of the day. Do you often do peripherals infrapopliteal nowadays, Dr. Remark?
Yes, sir. Yes, sir.
No, I was asking. I'm asking.
Oh, sorry.
Yeah. Dr. Remark, do you do, or do you really get time to spend this much time on peripherals?
No, I love peripherals.
All right. I still remember you.
In my cath lab, there are not many people wanting to do peripheral work. That is another thing why I continue to do peripherals after so many years, or maybe after a couple of decades.
What about your idea? What about your opinion on the placing stents in the infrapopliteal vessels? Here, there was no option because a lot of dissections occurred, isn't it? There was no way out. You not have
actually
avoided.
I read a paper in which one of the purpose of doing a peripheral angioplasty in this case is healing of the ulcers. And that always happens, even if the artery on which you worked, it closes, like stent goes into an ISR, long stent, diabetes, slow flows. Many will contribute the ISR. And even then, the ulcer heals. That is the most important part. I mean, that is where the patient is actually suffering. I think that's a huge achievement. It can get a smile on a patient's face. And I think we all love that. So I would probably feel that any way you can improve even some percentage supply for wound healing, it's a big relief for the patient.
And you use the superior's deployment technique is a little different from the other stents. Otherwise, it may offshoot. We may miss the lesion, or sometimes it may go up. So that's the only. It takes a little learning curve for the use of superior stent.
Can you tell a little bit more about this? What you said?
Myself.
Different technique. Oh, you can tell us, Sean.
The technique of using the superior deployment.
So the only difference is that our rotation wheel in the other stents, it doesn't. The stent is equal to the length of the stent. For example, if you see under fluoro 100 mm regular self-expanding stent, 100 mm is equal to 100 mm. But in a supera, it's 1:3. If it's let's say a 80 mm stent, it's compressed in such a way that inside the sheath, it's actually 3 times the length than a normal self-expanding stent. So what it tends to do is, like, the moment you start deploying, it tends to go forward a lot. So you have to have two-hand control to have a good deployment. First thing. Second thing, the diamonds of the stent has to be deployed properly, and that again comes with experience. You have to deploy with some magnification and deploy it very, very slowly. There is no need to push the button all the way. You can go halfway and slowly deploy it so that every diamond is deployed correctly. Because the biggest problem of supera is, if there is a 10% elongation or a 10% decrease in length, the patency rates significantly go down compared to other self-expanding stents. But we have no option in the popliteal region. You have to go for a supera. So the only thing is, sir, you have to take some time. You have to take 10-15 minutes to deploy the supera, and see to that the diamonds are beautifully formed. And
had there been no superior
3 hours procedure, I guess 10-15 minutes extra is not a problem at all.
Yes, sir. Yes,
if the stent is going to give you 20 years, 30 years.
Yeah, absolutely.
And had there been no superior, it would have been difficult, because we cannot put the other stents across the joint. It was across the joint, knee joint.
Yes, sir. We tend not to put, sir, but whenever there's a popliteal occlusion, at least for a bailout, it's better to keep the family informed that it is a costly stent, no doubt. But if there is no option, we have to go and put it across.
And you get in long, the length also up to 200. That is
yes.
what.
Yeah, that's the beauty. 180, 200s are available.
So they are. I mean, I have not used this particular one, but the length, they sort of adjust themselves to the diameter or the circumference of the vessel, right?
Yes, sir. Yes, sir.
Because
and the radial forces of
200 is a real long stent length.
Yes.
So upper end could be something like 8 or 10 mm. And lower end could be just 3 or 4 mm.
Yes.
I guess stent gets itself such a long length. This is probably because it expands where it should, and it doesn't expand where it shouldn't. And that is how you get a long length well covered.
Yes, sir. Yes. And that's why preparing the bed is very important before going for a supera. The other stents you can post dilate and it will be okay. But for a supera, you always have to upsize. Like, I used a 5.5 supera, but I had taken a 6 balloon just to prepare the bed. In fact, some of the Japanese masters, they in fact go to the extent of opening up the vessel to a 6.57 also. And high pressures, going for 18-20 atmospheres, which we normally don't do, almost breaking up the vessel. Because the elongation is the worst. So bed preparation of the supera is very, very important.
The staff should also know the preparation and the use of the supera, the deploy, the structure, or rather the hardware they use.
Yes, sir.
Because it's different from the other one.
Yes.
The back end, the removal of the check, the safety catch. So all these things are different.
Yes, sir. Yes, sir.
Srinivas has joined.
Good evening. Good evening. Good evening.
Wire that you used to penetrate the CTO,
Yes, sir.
you persisted with same wire all the time, or you changed
No,
your
sir.
wire?
I from antigrade started with a 035 Teramo, changed to a command 014, then switched to a Win 014, then to the Coronary Gaia 2, and after that I came retrograde using a V18 from Boston Scientific, which is a 018 platform V18 wire. So these were the wires which I used for this case.
Which one did you use in the retrograde?
V18, sir, from Boston Scientific, a V18 wire. It's my go-to wire always, sir, when I go over retrograde. It's a fantastic wire.
It's a stiff
So
wire.
it is.
Yes, sir. Nice floppy tip with the good stiffness, and helps to penetrate from retrograde even sometimes even without a support catheter.
So what kind of balloon can go over it? I mean, it is 018 wire, you said?
Yes, sir. Yes, sir. We do get 018 balloons now, sir. For Abbott as Armada 18 018 wires compatible balloons right now. But I generally tend not to put a sheath from down. Just take the axis and go sheathless. Only the.
Yeah, you showed us you kept that balloon inflated.
Yes, sir. Only the support catheter. Yeah, only the support catheter and the wire. I don't put a sheath generally in the retrograde. Once I cross from retrograde to antigrade, then try to get a body floss, pass the wire into the catheter from antigrade, and then have a pan leg wire, one from the groin, one end in the groin and one end in the ankle region. So that gives me a tremendous pushability from above.
Yes, I think if you have both the ends outside.
Yes.
I mean, we use that in CTOs, complex CTOs, long lesions and things like that, even in coronaries. The balloon gets a very strong support from both the ends. So
yes,
the
yes,
balloon can go through the CTO very well.
Yes.
Excellent case, Dr. Shravan.
Thank you,
we
sir.
all learned a lot from this case.
Thank you.
So
Thank you.
patient goes on anticoagulation. You did start with 20 milligram of
Yes, sir.
rivaroxaban.
Yes.
So he stays on rivaroxaban for a long time, or?
I tend to keep it till the wounds heal, sir, which is like 3 to 4 months period. And once the wound heals, then I switch over to either single or dual antiplatelet with the 2.5 rivaroxaban.
0.5 rivaroxaban is not considered to be an anticoagulant dose.
Yes, sir. Not for anticoagulation, just for the prevention part. But till the wound heals, I keep on full dose, 20 milligram. Most of the patients heal their wounds in 3 to 4 months. After that, I switch to either single or dual antiplatelets, aspirin or clopidogrel, and put them on 2.5 twice daily rivaroxaban also.
Dr. Srinivas, you can hear me, or you can hear all
sir,
of us?
Good evening, sir. Good to see you again, sir. You're looking like old Hiramat, sir, again, sir.
So, right now, the patient is discharged on 20 milligram of rivaroxaban, clopidogrel, and aspirin. Would you like to suggest some changes which are probably useful in long term? I mean, what Dr. Shravan, we are talking about from coronary experience is that aspirin is not of a great help.
Yeah, no, aspirin I didn't put on aspirin, so only clopidogrel and statin, sir.
And rivaroxaban.
Yes, sir.
We are talking of blood thinners right now.
Yes, sir.
Let's keep something else aside. So you had patient on aspirin, clopidogrel, and rivaroxaban.
No aspirin, sir. That's what
no aspirin, sir. Only clopidogrel and rivaroxaban, sir.
Okay. I think we should all probably follow this so that we don't produce unnecessary
bleeding,
hematomas and ulcers, hematomas related to aspirin. So whenever you're using a combination, I think very often aspirin is the first one to go away. Dr. Srinivas, same with you?
Yes, sir. Yes. Now, actually, gradually we are using less and less of aspirin. In HBR patients, we are stopping after 1 week also. So it is like one thing I just wanted to. Sorry, I missed that case to comment about the case. Seemed to be a good case because of now COVID cases becoming less. Our regular work has gone up significantly. That's how I should just catch up. This I missed that presentation, but probably it was a good case. One thing what I've learned in this peripheral case, sir. Initially, I used to do. Later, I left it to one of my junior colleagues. He'll be specializing on that. But basically, you need to plan the procedure and plan the timing and radiation exposure. Otherwise, you get a lot of radiation too. And that's also important, not only for patient as well as the operator. And the beauty of this is it need not be a perfect result, smooth result. What I have noticed, even if you give some blood flow also, these wounds heal, and many times we could avoid amputations. Need not be a perfect, smooth result like in coronary. That's what I noticed. Maybe restenosis and all, maybe more that I have not seen. But immediately saving the limb and healing of ulcer happens even with partial improvement of blood flow also. So that also gives a lot of happiness to us as clinicians, as sir said.
In fact, I was mentioning the same thing.
Yeah.
That 40% of the good work that we do in the cath lab is all gone in a few months' time.
Mm-hmm.
However, patient is happy because his ulcers are healed, and somehow he's able to put in a bigger effort than before. So it serves the purpose, though artery may or may not be patent.
Yes.
Dr. Shravan, what is your experience on this?
That's very true, sir. That's very true. Because sometimes it seems there's nothing going down directly into the foot and just a leash of collaterals going down. But that is also enough. Depending on the extent of the wound loss, we take a call whether to go in some more. Sometimes it's just small ischemic ulcer in the tip of the toe, that kind of wound and all, it heals completely. The times when we go all the way trying to get a complete flow, direct flow to the foot is when the patient is having a transmetatarsal amputation or a very large wound. So, but most of the time, like you rightly said, sir, if you establish a good flow and post-procedure, we always check the toe brachial index and TCPO2, which gives a very good indication whether what you've done is enough or not. So that's a great indicator for us.
Yeah, actually, this is what I tell my fellows also, that you do an incomplete job on the lower extremity, even then you would find a happy result. Yes. So I actually suggest to them many times that they do peripheral stenting first before they come to coronary. And coronary is something where you need to be very, very good in your final approach. In fact, so many times we do intravascular imaging just to make sure that there are no red spots seen on the stent. And the stent is very, very well opposed inside the intima. So, Dr. Onkar, can we go to the next case?
Yes, sir.
Who is presenting?
Dr. Kaustubh, are you there?
Kaustubh, we just see him leave his seat.
Yeah, I think then we can go ahead with Dr. Samir Malhotra.
Sure.
Dr. Kaustubh, we are. I think he's not. Yeah.
So, can you see the screen?
Yes.
Good evening, everybody. It has been a long time since I did this case, and I was thinking about discussing this case at the right forum with the experienced panel. And I'm very happy that Emcure gave us an opportunity to do that. So this was a bad case for me as a cardiologist, but I think it will give me a lot of learning points. This was a nightmare in the cath lab. We started as a 55-year-old male, known case of ulcerative colitis. He was on steroids and disease-modifying agent from the last many years, 10 to 12 years. Diabetic, hypertensive, non-smoker, so many comorbidities. He had an angioplasty to LAD that was done in 2015-16. Presented to us with acute ST elevation MI. EF, which was previously mentioned in the papers as 45 to 50%, had dropped to 35%. LAD was totally hypokinetic. We did the angio. It was triple vessel disease with 100% instant restenosis in LAD. As usual, we talked to the family, did a primary angioplasty to LAD with good result. I'll show you the angio pictures also because Somehow I could not just connect them to the PowerPoint presentation. So in the hospital post-procedure, the patient had an uneventful course for the next 24 to 36 hours, but then he developed non-hemorrhagic pericardial effusion. Why I say non-hemorrhagic? Because when his pericardial effusion became significant and it was symptomatic, we tapped the pericardial fluid. It was non-hemorrhagic. And we were quite surprised. We thought might be patient is having pericarditis, post-MI pericarditis. It was because especially it was after 48 hours. We tapped it, patient was stable, mild chest pain that responded to tramadol and Voveron. And after that, patient was stable, mobilized, discharged after 3 days. Within a day, rather the same day after discharge in the late night, patient said that he was having chest pain without any breathlessness. And patient came to the hospital. We saw the ECG. ECG did not show any fresh changes. The 2 enzyme sets were done. CPK-MB as well as troponin I was normal in both the sets. Patient's pain was not typically cardiac. It responded to Voveron. And in the morning, the patient was asymptomatic. I don't know why, but then I said that since the patient had such a stormy course post-procedure, normally we don't expect a pericardial effusion and then patient coming back to you again the same night with chest pain. I said, let me just do the angio. And that is when the nightmare happened and it started. So just I'll be showing the images.
So for to keep the ISR, you put one more stent or you did not?
I'll show you, sir. I'm showing all the images, sir. I did put one stent, sir, in ISR, sir. Opened the artery. This was the right coronary artery, mild plaquing, diffusely diseased vessel. This was the left. You can see the circumflex. This is LED.
No, Dr. Samir, we are not seeing, at least I am not seeing.
We are not able to.
Dr. Samir, we are seeing your slide in hospital course, but we are not seeing your angiography.
Okay, just a minute, sir. Just a minute.
Yes.
Yeah, right. Now,
can you see it now, sir?
Yeah, we can see.
So I'll show it from the beginning, sir.
Yeah. Right.
So this was the right coronary artery. You can see it's a diffusely diseased vessel. The PD and PLV are significantly diseased. This was the left. You can see left circumflex is normal. There is a ramus, which is mildly diffusely diseased. This OM is also diseased. And this LED, this shows in stent 100% thrombosis. And there was a huge long stent which was placed in the LED, and this is showing 100% in stent restenosis.
So this is 5 years after the initial implant.
Yes, correct? Yes, sir. And the one more thing I forgot to tell, the one thing, the patient had stopped clopidogrel. He was on a single antiplatelet, that was aspirin only. That was one thing. And he had stopped it from the last 1 year. So this patient was on a single antiplatelet. It was on the face of it, it was a routine case, primary angioplasty. We started doing the procedure. It was an all-star wire. After that, we started dilating it with a 2.5 followed by a 3 balloon. These are the sequential results. You can see the distal LED is also diffusely diseased. Although the blockage was here in the mid part of the LED, but the distal LED doesn't seem to be a good sized vessel.
How was it when they did the angioplasty?
Sir, I didn't have the old records actually. I didn't have the old CD. It was done 5 or 6 years back at some other hospital. He had chest pain, so he came to the nearest hospital at that point. So I didn't have any of the old records, but this is what I had on table. We balloon dilated it. But there was a point here at this point where we could see that the previous stent was not fully expanded and there was some disease here also. We gave sequential dilatations.
Did you do any imaging from inside?
No, we didn't have any imaging facility in our house at that point. So it was night time. We didn't do any imaging. We put a stent from ostium to mid LED. It was a 3x38 millimeter stent.
So how much are you covering the whole stent?
Sir, I didn't cover the whole stent. I covered till the distal to the occluded segment. The point at which the LED was occluded, I went distal to that. I didn't cover the whole stent up till the distal endpoint of the LED because it was seemed to be a diffusely diseased vessel and the diameter was also very small. So
the two stents are not touching each other.
Which stent? The previous stent, sir?
Previous
No,
stent
this
and
stent, this stent I totally see. This was the osteoproximal LED, which overlapped with this previous old stent, and we overlapped it from here up till here. It was a 38 millimeter stent, 3 into 38 millimeter.
but you were saying you did not cover the old stent completely.
Yeah. The distal part of the stent was not covered. The distal part of the stent I didn't cover. It was only up to the middle part of the stent where the LED had got occluded. I covered only at that part. And I expanded the previous stent, the distal part. This whole part was not covered, sir. You can see these two markers. This is the point of overlap.
Yeah, we can appreciate it very well.
Yeah.
During the procedure, you can get mag and things like that, or you can use a stent book stent.
Yeah.
Sure that these are overlapping.
So this was the final result. After that, this is this was the final result. After that, when the patient had chest pain the night and we readmitted the patient, somehow I thought, I don't know what, but let me check the angio once again. And this is what I got on the angio. See, a lot of thrombus in the LED. A stent had got occluded, but it was a flowing vessel, but there was a lot of thrombus in the LED stent.
What was your discharge treatment plan?
Aspirin and prasugrel. I had discharged the patient on aspirin and prasugrel. I usually prefer prasugrel compared to ticagrelor. So I had discharged the patient on aspirin and prasugrel.
Why do you prefer prasugrel?
I find it easier from the patient's compliance point of view. Otherwise, if you look at it, more or less, both have the same platelet inhibition. But giving prasugrel once a day to your patient compared to ticagrelor twice a day to a patient. And when nowadays we have combination of prasugrel with 75 milligram of aspirin. So we usually combine them and give them a single tablet.
Let me ask somebody else. Jabir, what is your strategy? You are a prasugrel man or
we are ticagrelor people.
Yeah, most of the people are ticagrelor. There are very few people who are prescribing prasugrel. We have been doing it from the last 8 to 9
my
years.
own feeling is advantage is OD prasugrel.
Yeah.
But the duration is very long. I mean, almost 7 days compared to 3 days of ticagrelor. So if you run into any kind of other problems and you have to stop antiplatelets, ticagrelor is easy to stop. Dr. Srinivas, what is your ticagrelor or prasugrel?
Normally we use ticagrelor, but this is the only place in stent thrombosis is the only place where we use prasugrel, because indication-wise, this is the indication for prasugrel is written also in a thing. So only in cases of stent thrombosis, sometimes we are preferring prasugrel, because potency-wise, we feel prasugrel is definitely more potent. That's how the bleeding chances could be also a little more. And ticagrelor is optimal potency versus efficacy, and then probably least is clopidogrel. That's why when you want a maximum, probably.
Dr. Samir, the first time when you did the angioplasty on this gentleman,
yes, sir.
That time also you used prasugrel. It is not when he came back.
No. The first
I'm
time
telling Dr. Srinivas, it's
only in stent thrombosis we are using
Correct.
prasugrel. Rest of the time ticagrelor.
No, but Dr. Samir used.
I use prasugrel.
First time when he used.
I use prasugrel. I usually prefer prasugrel. Your perspective is absolutely correct, sir. But many times we have seen patients who are already on ticagrelor, they stop. They sometimes, because of the cost constraints here, they say we have started taking it once a day. So many times we have seen such cases also, and then it becomes difficult. I find it very comfortable to keep the patient on a single daily drug.
And so, we used to give the original molecule, the Effient, by the medicines company. It was 140 rupees at that time. We had a couple of bleeding events, but later on what happened was the Effient was gradually taken away from the Indian market. And now we have a lot of the generic the generic brands available with prasugrel, which are rather cheaper variety.
Yes,
I think there is a financial benefit also. It costs somewhere around 15 or 16 rupees also.
Yes, sir.
Only. I do use prasugrel. I do use prasugrel, especially in those patients who have good body weight, presenting with STEMI taken up for PAMI. And second is those patients who have a high risk for a stent thrombosis, like long stents, bifurcation in the setting of PAMI and all. But predominantly it is ticagrelor when compared to prasugrel. Prasugrel may be 10%, and then for 50% or 40% may be ticagrelor and rest clopidogrel.
I personally think, sir, whether it's prasugrel or ticagrelor, it doesn't make much of a difference, except for the fact that, as sir rightly said, if you have to go for some urgent surgery or procedure, you have to stop ticagrelor for 3 days and prasugrel for 5 to 7 days. That's the only difference I personally feel, sir.
It's a huge difference.
Yeah.
For people who need a surgery for road traffic accident and things like that, those 3 days and 7 days is a big difference.
That can make a lot of difference. You are absolutely right, depending upon the clinical situation, sir.
And the current guideline says you cannot use prasugrel until you know about the anatomy. So preloading is, for that matter, preloading is not recommended for ticagrelor also in ACS.
We do it in the lab itself, sir. 60 milligram is stat in the lab, sir.
And now with the IV cangular, I think we can take up the patient on IV cangular and see the anatomy and shift over to prasugrel.
Absolutely, sir.
Jabir, are you comfortable using prasugrel in thrombolytic setting also? You're saying in...
No, not at all. Not at all.
You said something when a patient is on acute MI? Thrombolytic, direct primary PCI you tell.
Direct PCI, not thrombolytic.
So thrombolytic, again, prasugrel is generally not comfortable. No, wherever there's more bleeding.
Jabir doesn't know thrombolytic therapy.
Ticagrelor, now we have good data. Even with thrombolytic therapy, it can be safe.
Yeah, with the data of the...
Yes.
I don't remember the name.
So, well, definitely this was what happened. And then this was the result final, which I achieved post-procedure. Seemed to be a decent result. And then the patient was discharged.
So, Dr. Samir, you sort of, the way you told us, we thought you were quite reluctant to do an angiogram, yet you did it.
Yeah, I don't know, sir. I still don't have any.
So what was the driving point? We want to know that, so that
somewhere in my mind, I was thinking, why is this patient having so many issues? The patient had a pericardial effusion. I expected it might be hemorrhagic. It was non-hemorrhagic, straw colored. Then I thought might be again when he came, his pain responded. I said, what is it that he is coming again and again? Let me just try to be on the safer side. Let me just do an angio. It will hardly take 5 minutes. I took him to the lab, and this is what I get, sir.
You all keep a low threshold for doing angiograms in a post-procedure patient, isn't it?
This is what I get. This was the tapping thing. This is what I get.
But generally, Hiramat sir, by and large, if patient goes to stent thrombosis, it presents in aggressive way, and ST elevations and ECG.
Yeah, that was surprising. No ECG changes, sir. Enzymes were negative. Patient was comfortable talking. And I said, okay, because you had a pain, and let me just do the check angio.
I would probably feel, since you were the angioplaster the first time, and you know how many difficulties you faced, probably that was the driving point that you wanted to recheck.
Actually, sir, I'll be very honest with you. It was an osteoproximal LAD stent. Patient also had a previous stent, and so such a long stented LAD. The second thing was that distally the vessel was diffusely diseased. And then he had a pericardial effusion, and then he again came back with chest pain. Everything just made me think, let me do a check angio. And I think that, I don't know, I personally retrospectively think that was a wrong call. And I'll tell you, this was the LED which I saw. Now the query at this point, the deciding factor was whether should I go and tackle this. Patient was totally asymptomatic. ECG
I have not understood what you're showing now.
Now I'm showing, so the second angio when I did, I'll show you this. This. So there's a thrombus in the stent, you can see that. The second time when I did the angio. There's such a huge thrombus burden, and the patient is, just a minute. Yeah. There's such a huge thrombus burden in the LAD stent, and the patient is totally comfortable.
What about the GP blockers under this setting? Do you?
Yeah, that is what retrospectively I'm thinking, sir. That what happened was that at this point I had two things in my mind. Should I do a thrombolysis? Should I go a GP2B3A inhibitor, or should I just go and just post dilate the stent or do something for this thrombus? Patient was totally asymptomatic.
My steps would be aspirate, give only intracoronary GP blocker, and then stent.
So,
so I don't maintain a IV infusion in the CCU and all, you know. So
and one more concern was that it was such a huge thrombus burden. What if it comes back proximally while I tackle this thrombus? Because it had definitely not formed acutely. अगर acute होता तो patient को कोई symptoms होने चाहिए थे. मतलब 1-2 दिन पहले ही हुआ होगा. Whatever, whenever it had happened, I don't know.
Samir, believe you are a champion and just go ahead. You know.
And sir, I went that and I think I made a wrong call, sir. So it took me a lot of courage to show this case, but I made a wrong call, sir. I'll show you. So it seems fine at this point. Again, there's a thrombus. We dilated it.
So you have your second stent in already now. What you're showing?
No, I didn't stent this time. I just dilated it. And then what happened? See.
Oh.
Then everything was a mess. We couldn't do anything. Every CPR started. Everything started. Nothing could be done.
So first procedure, how much was the gap between the first and second procedure?
3 to 4 days, sir. 4 days.
And this is the third procedure, what you're showing?
The first, no. So the first procedure was when the patient had angioplasty. That was done. After 48 hours, the patient had a pericardial effusion that was tapped. After 2 days after that, the patient was discharged. Morning patient was discharged. Same day, night, the patient was readmitted around 11 or 12 o'clock.
And then you saw proximal LAD showing
that night I didn't do the angio. Next day morning.
Whatever, next morning.
Yeah. So I saw that this was a thrombus.
So patient had 2 procedures.
Patient had 2 procedures, sir. And I was thinking most probably it was a wrong call to take the patient who was totally asymptomatic and do.
No. I mean, this LAD would have killed him anyway.
I don't know, sir. What retrospectively, this is my thought process.
You can't expect a mid-segment stent and proximal LAD showing so much of thrombus. In a short while, he would have got totally occluded. And then there is no question of saying that, oh, he had no symptoms and things.
I was thinking that I should have thrombolized or given 2B3, as you rightly said. I was thinking about that, sir. Retrospectively, sir.
My strategy, in fact, is to use a bigger diameter stent.
Yeah.
Like this vessel was, say, 3.5. I would put a 4.0 stent so that it opposes to the vessel wall very easily at low pressure. And you can manage with the low-level anticoagulation. In fact, I would probably feel that giving ticagrelor under these settings, when you also have some contraindication like pericardial effusion, which might increase, I would probably feel that ticagrelor is a little bit safer than prasugrel. Maybe you should deviate from your usual thinking and be like commoner.
It's very unusual. Because we do not know what is the reason behind that stent thrombosis, because this guy had a stent initially. He was on clopidogrel. He didn't develop any issues at that time.
One thing which I was thinking was that this guy, because he had ulcerative colitis and interstitial lung disease also, the chest team had started him on steroids. That was one thing which was coming to my mind. But
don't know what can steroid do, but
I don't know. I'm just contemplating putting on all the possibilities, sir.
No, I don't think steroid do any harm.
The ulcerative colitis is a prothrombotic state, but had it been a prothrombotic state, he should have developed it earlier also.
Yeah. And it was 5 or 6 years old distance.
We must appreciate you for presenting this case, the courage to show this case, which I think it's a case for real discussion. What has happened? Why did it happen? We don't have an answer. Why did it happen? Why did you develop a stent thrombosis?
I
And what
still
else-
don't
what
know
else
what
could have
I
been
should have
done to
done.
prevent this stent thrombosis? Was
Yeah.
there anything else? You post-dilated. Did you post-dilate the second?
Yeah, I post-dilated with 3.5. Osteal lesions, osteal LAD lesions, there is no point not post-dilating them with a high-pressure balloon. And I usually take NC balloons on.
What else? What else
I
can you do? You put the patient on prasugrel. You post-dilated well, pretty big stent, decent procedure, well-opposed stent, well-dilated stent. What else? Only thing is an imaging would have tell us what exactly had happened. But here OCT may not be helpful because it's full of thrombus. It may not give a correct picture. You will not be able to clear the blood with the you will not be able to get a good clearance.
Yeah, IVUS can tell you whether the stent is fully expanded or not.
I usually 3.5 and I usually go to high pressures because we do IVUS at times and we have realized this, that what we see on imaging is many times under expanded stent. So that is why I have a habit of doing high pressure stenting usually.
No, that we all do, but IVUS may is trying a difference, like you have 5 good students. Somebody who's got 100 out of 100 and somebody has got 99. That difference IVUS can pick up, you know.
Yes, sir. Absolutely.
So I would feel eyes and brain. Add IVUS to that. I think it will probably 100. Otherwise, eyes and brain are 99.
No, IVUS is always of additional help. Sir, imaging always helps. It changes our the way we look at these lesions also. There's no doubt.
Samir, the only place where we tend to avoid, as sir was telling, to avoid too much high pressures is where you tend to think that there could be slow flow possibility. So
Thrombus.
probably taking a bigger diameter and optimally placing could be a solution rather than going to very high pressure, which squeezes out all the material out. And that's how everywhere the thrombus lands in. So rather than that, just as sir mentioned, take optimal size and just patch it up everything slowly. So that chance of slow, that is only a possible theoretical discussion post.
Dr. Srinivas, since you're mentioning at this point, in fact, whenever you are doing a thrombus-laden artery, we go very slow on inflation.
Yes.
So the distal ends, they swell up and the mid portion is still very narrow.
Yes.
By doing distal end, I always take a few millimeters extra length stent for thrombotic, so that the distal embolization is probably stalled when the mid portion is getting the fullest pressure. And as Srinivas mentioned, try and finish up with a pressure of 10 or 8 with a slightly half size extra diameter stent.
What about aspiration? I just want to know whether Dr.
He did it before. He did the aspiration.
Aspirated, then I did a balloon dilatation and everything in the second sitting. But somehow, I don't know whether while I was pulling back the aspiration catheter or balloon, how did the thrombus migrate proximally and occlude the left main? I was just thinking there were so many possibilities.
No, I would also feel that the aspiration catheter many times has a thrombus sticking at the mouth, at the inside end.
Yes.
And as you're pulling it back into the guide catheter, that's the time it gets loose.
It's lost.
And stay there or go again into the vessel. Anyway, a lot of learning from this case, Dr. Mehrotra. And thank you indeed for showing this. So, Dr. Kaustubh, ready?
Yes, sir. Only there is technical issue, and I think can we continue with the without full screen, or I will directly run the videos scenes from my video site.
Yeah, no problem. Anything that's
okay. So, so my screen is visible now.
No, slides are not visible, but we can
The
see.
screen is visible. We can see the your AVI clips, but it's not running.
Okay. So slides are still not visible?
No.
Slides are not visible, Kaustubh.
Okay. So I'll directly run the videos. Videos, can you see? Hello?
No, you have to share that first.
Presentation 30. So, slide.
Can you see now?
If you share. Yeah, I will do it. So here down. Okay. And it should be with the laptop.
You can open first the file, and once the file start running, you can then share.
Now can you see?
Yes, yes. We can see now.
So now this 71-year male who had inferior wall MI, he came to me post thrombolysis, and I did his angiogram, and he is also diabetic hypertensive. He had triple vessel disease, and there was critical lesion in OM and LAD, and RCA was totally occluded from proximal segment. So I advised him for CABG, and this is the RCA. You can see that proximal segment is totally occluded, but this man didn't undergo CABG, and he came to me after 6 months with chest pain again. And at that time, I asked him why he didn't undergo CABG. So he said he don't want to undergo CABG. Then I gave him option that we can do multivessel angioplasty. So then RCA, as RCA was CTO, then I decided to, I told them if I can open RCA, then only we'll plan LAD and OM stenting. So we decided to go with RCA angioplasty first. At this time, he was having mild LAD dysfunction, and his tropi was around 1000. So this is the RCA. This is JCTO score 2. There is mild calcification, and there is long segment chronic total occlusion. So first I tried with the run through wire, but run through, you can see that I'm not able to go ahead after this midpoint. So I switch over to Fielder FC wire, and to my surprise, it went very smoothly inside the vessel. And that time I thought just I will make some passage. So I took 1.5 Ryori balloon and just slide over in the on the Fielder FC wire. I didn't inflate, I didn't do any dilatation, just to check if I am in correct path or not. So this time you can see some dye coming out from the vessel. So I have pulled the run through wire, and the Fielder FC wire is inside, and there is jet gush of the blood coming from the proximal segment of the vessel. So here I thought that it might have perforated, and then I just took from LAO to epicranial view, and here I can, to my surprise, I saw which was like two parallel wires, it was seen in the LO view, but now I can see I have went in the wrong direction from the channel. So there was a perforation. Meanwhile, I could negotiate my run-through wire into the RCA up to distal end. This perforation, I tried to seal this perforation by using balloon, but it didn't seal. Then next thing what I did, I used micro catheter, fine cross. I went up to the perforator level. Then I tried to inject some clots inside the segment, but it didn't close. And then I tried to give negative suction to the microcatheter. That also didn't work. And actually, that perforation worsened when I did this step, and patient started going into shock. So this was the microcatheter step. There was one more option for me because I had a covered stent, and I have entered the true lumen and went into the native vessel. So I decided still I can open the native vessel and put covered stent across the perforated segment. So I dilated the main vessel with 1.5 balloon, because 2-3 attempts with different thing didn't work out, and this was the option. So with 1.5 balloon dilatation, I can see some of the vessel, but the perforated segment was still oozing, and his BP started dropping. So I put I did pericardiocentesis and put JR catheter. So, and simultaneously I started doing aspiration and put the distal stent 2.75 to 48 tetrilimus regulating stent was placed first in the mid segment. Then I placed 3 into 24 tetrilimus stent, and now this is the graft master 2.8 into 16, which I placed across the perforated segment. This I put at around 16 atmospheric pressure, and then I dilated with 3.5 balloon to have optimized result. Now this was the final result, and the sealed segment was not completely actually sealed. There was still some oozing, and which was expected. So I kept that drain for another 3 days. Every day there was 50 to 100 ml drain was coming. Last day the drain quantity reduced, and then I removed the drain, and the patient was fine hemodynamically. He took almost 7 days. Inotropic support was there for 5 days, and on 10th day he was discharged home. Now also he come to OPD and he's doing fine.
What about the 2 lesions on the left side?
He didn't come for that, sir. He didn't want to get operated at present.
Well, I think it's very courageous when you have perforation. Still, you got into the distal vessel, put 2 distal stents, and finally the covered stent, correct?
Yes, sir.
The covered stent was the last one to go.
Last one, because I thought if I put covered stent before, it will get clot because there is no distal flow.
Yeah, Dr. Jabir, you would do the same, or you would?
I would do the same, because I may find it extremely difficult to track another stent through the covered stent also. So I'll cover. Only thing is, you need the time. That fortunately he could do the aspiration, and patient was hemodynamically stable for the rest of the procedure.
I was simultaneously doing auto transfusion also, sir, for this patient.
He gave you the time.
Yes. His BP came to 60 systolic, but I increased the inotropic support and continued after every stenting, I was aspirating around 50 to 60 ml, and then his BP was again improving. So I could place another stent like that, simultaneously aspiration and stenting was done, and I am the single operator, so I had to do both things simultaneously.
And seeing the initial oozing, I thought it may get controlled with balloon dilatation.
It didn't improve, sir.
Did you reverse the heparin, or the same dose of heparin was continued?
No, I didn't give extra heparin, but I didn't reverse it.
Which covered stent did you use? Graftmaster?
Graftmaster, yes.
So what is the objection of taking a stent through the Graftmaster? It doesn't go?
Doctor, that was a curvature also. We may find it difficult to track the stent down.
Sir, one question. If there is no distal flow, still I can place covered stent at the site of perforation, or I have to open the vessel first and then put covered stent?
No, I mean, if this case was to get bad, you would probably put a covered stent and not worry about a distal vessel at all, isn't it?
Yeah.
It should be the covered, because the covered stent, the perforation is going to kill the patient. The lack of flow in the distal lumen.
Yeah, as long as you're sure you're in the correct lumen, the wire. I think covered stent. In fact, I would probably feel that I put the covered stent first.
Okay.
And only if the patient stabilizes, it means a lot putting two distal stents, something like that.
Okay.
So first issue is leakage stoppage. And only if that happens, your patient is going to survive. So
yes.
Then I would go through the stent. But Jabir, I didn't understand why your stent cannot go through a covered stent.
No, bulky, no, sir. That is the only thing. Covered stent is bulky. Even the regular stent, sometimes it is difficult to track through the stent. The covered stent is more bulky. That's why you could have resistance.
No. But have you faced such?
No, many times no. As you said, sealing the perforation is a top priority. One more thing is, without sealing perforation, if you put stent, you had to stop antiplatelet and all, that stent also might close. No, that's why perforation sealing is a first priority. Sometimes you don't get time also to do anything. You have to do it immediately.
Yeah, I mean, here there was a pericardial tapping, which was actually helping the patient a lot. Like every time you
was getting
50 cc's,
hemodynamic stability was coming after
it was sort of encouraging you to put stents. Yes, so it was encouraging you to put covered stent there.
Yeah.
Regular stents, and then finally the covered stent.
Yeah.
But anyway, very thought-provoking steps that you, despite so many difficulties, you put the DES, 2 DES, and then finally covered stent. The only variation I would do is probably put the covered stent
first.
You are happy,
yeah.
Like patient is going to survive, and then there is a point in putting 2 DES distally.
Yeah.
And it was not an absolute recent approach. It was more than 6 months.
6 months, yes.
Both operator and the patient has to be lucky sometimes, I keep telling.
I would say
in the process of putting 2 stents, sir, you won't get that much time because he was tapping. I think he was lucky enough to get some time.
I almost tapped 250 ml of
and he was a single operator.
And some of his assistants may be continuously
auto-transfusing it.
They may be continuously aspirating. That's why the patient had some hemodynamic stability, which helped him to put the other stents.
No, but that suggests that you see, sealing perforation is important and you need to address it before. So that is the message we want to tell everybody, that whenever is a perforation needing repeated tapping.
Dr. Srinivas, I would feel the intervention cardiologist should have courage like Dr. Kaustubh.
Yeah, I appreciate him. Thanks for showing this also. Patient survived.
The leak was going on when he's putting distal stent. The leak was going on.
Yes.
So he was aspirating and putting a stent distally. I think that was very courageous.
One is it recommended is perforation. 1-2 types where it is not communicating directly, not leading to pericardial effusion. Though minor perforations, what you said is right. You need not be worried. You can still address. Ischemia becomes more important then. But in the major perforation where it is all leaking into the pericardium, The recommendation is to first seal the perforation.
No, Dr. Srinivas, I will tell you one more thing. I had a perforation, and the perforation was into the left ventricle.
Yes, that they will tolerate, sir. Left ventricle perforation.
Exactly.
Nothing happens.
So I was seeing, and I could see the contrast come out.
Yes.
But at the same time, I could see the LV contraction, and nothing happened.
Nothing happens.
We waited next 20 to 30 minutes. We didn't have to do anything.
Yes.
And we continued.
That happens. That also usually, if we perforate septals, it won't create much issues. But if it is diagonal, then we are in trouble.
Yes, absolutely.
This case, I learned few points, sir. One was that when I put the wire, I should always see that wire in two orthogonal views before even just sliding the balloon, 1.5 balloon without opening. That can also be detrimental if we go through the bridging collaterals. This was the second learning point in this case. And third was always we should have covered stent in shelf to tackle such kind of situation.
But it's very commendable in Parvani, you have all these available to you. So it must be a very good effort on part of the cardiologist group there to make these things available. Many times, even in
and he's a single operator. He has managed all these things: the aspiration, the covers, and then further two stents down the lesion and complete revascularization of the RCA.
You have a follow-up, doctor, 6 months now, you said?
Yes, sir. 6 months. He's doing fine.
Kaustubh, could you run it again the way you put the distal stents with the perforation on?
You can't discredit in any way he has put the... I think it's very commendable effort.
No, we just want to see it because we never seen it before.
No. As you all rightly pointed out, whenever there is perforation, we don't think about the distal vessel.
Yes.
We will be worried about close.
He was having ongoing pain also, sir. I thought
true.
was also important.
We have shown examples, Jabir, that where to complete the procedure in spite of minor perforations, agreed. But not a perforation where it was hemodynamically stable, pericardial effusion unstable, and pericardial tamping needed and all that.
Yeah, I mean, the pain could have many reasons, you know.
Yes.
And under these kind of setting, it could be even
pericardial.
A cardiac massage, which fractured some ribs, and you was getting pain from there. What do you want to see, Dr. Jabir?
No, I just wanted to see it. How did he get the courage to go in when the perforation was going on? Right.
Well, I think he must have depended a lot on his judgment, whether the wire has gone through correctly or no. I mean, there is a clear possibility that you could be nowhere in the vessel and you are trying to take a stent in.
With 1.5 balloon, I dilated, sir, and it was in correct path.
Yes, correct.
Yeah.
So I think this step was very important. Jabir would have done IVUS, I guess, to make sure.
In this situation, I would first cover the perforation. Then only I will think of doing anything else.
No, that's what even I was thinking. And you guys say that you can't take another stent to the...
No, I may forget about the RCA. I may forget about revascularizing. Save the life first.
Life is saved. You put a stent and there is no leakage. So you might as well come out.
Then we may try. Then we may try.
Yeah. So here you can see that I am in true lumen now.
Yeah. But by this time, I think the perforation has come down a little bit. So the oozing is less. Now the dye is not staying too much.
Yes, sir.
Also going in the aorta, actually, you know.
Excuse me, sir.
Dye is also going in the aorta in this view.
Yes, sir. Yes, sir.
Now it has come down significantly. The perforation has come down. With the perforation is sealed off partially. And the hemodynamics are...
Yeah, here he's a little better at this point.
I think that gives you the
No,
courage.
these are the first steps, sir, because here I have not placed the pericardiocentesis. I have not done till that. This time his hemodynamic is stable. His blood pressure was still 90/100.
So when you decide to do a pigtail pericardiocentesis,
His pain increased and there was an increase in the shadow around heart. Sir. At this point, when I did negative suction with the microcatheter, still he was not responding. This time I decided to put pigtails and start pericardiocentesis.
No, I'm asking you, what are the criteria that you need to get to the pericardium? Is the systolic pressure, or it's the echo decision based on echo, or
echo also we can decide, but echo I didn't do that time. On just basis of the cine images that I see perforation, and here I can see the surrounding the heart. I can see the area suggestive of pericardial effusion. So I decided to put pigtail in that. That time I brought the echo machine and did echo and put drain.
So can you summarize how, I mean, it was a 6-month-old total occlusion.
Yes, sir.
Not a very old occlusion.
Yes.
So you went with a JR guide catheter.
Yes.
And your first wire was?
Run-through wire.
And the perforation was with run-through wire or your
Filter FC. Second wire, sir. Filter FC wire.
Filter XT.
Yeah.
I think these wires, they're very good to go through the vessel.
Yes.
But also you never realize where you're...
It went so smooth, sir. I even didn't feel any resistance. Like.
So the smoothness is a downside, I would feel. I mean, if you hit the wall, come back, then change the direction. If those are the standard steps, the wire goes. If wire crosses and it goes very smoothly all the way down, you are in the pericardium.
Pericardium, yeah. And that time also it was seen like parallel view. Like if I would have changed the view and I would not have slided the 1.5 balloon, I think that perforation would not have been that large.
Very true.
Just with the wire, yeah.
Very true.
Yeah. So the simple step of seeing wires into orthogonal views without contrast help a lot while doing this CTO cases. That I think I will always do.
You know, the wrong other side of this statement is that in LAO view, the wire went and it went exactly the way RCA would go.
Yes.
And that's a very exciting thing that, you crossed the lesion.
Yeah.
And that's how you get that 1.5 balloon and work on the wire. And that's how you
yeah.
Kausab, why didn't you start off with a retrograde injection from the left?
Yeah.
The fact that you are the only operator?
No, I thought, I should have done that also, sir. If I would have given that injection, it would have made things a little simpler.
That would have been the best way to find out whether you are in the true lumen.
True lumen, yeah.
These type of cases, it's always better to have a contralateral injection from the beginning onwards.
Yes.
Dr. Jabir, I would feel 6-month-old infarct and total occlusion. I would probably put a wire without making too much effort from the contralateral injection. I mean, it's unfortunate that this thing happened, but there are so many of us who go with just one guide catheter and all right, Dr. Onkar, looks like we are coming to the end of the today's program.
Yes, sir. Yes, sir.
Congratulations, Dr. Kaustup.
Thank you, sir.
I think all the presenters today took us to a different level. And Dr.
Complications are always interesting, sir. You show
Yes.
complications, it becomes more interesting and more discussion prone. That's
and the complications are dealt by each person in a unique way.
differently.
Yeah.
Differently. It is not there is no uniform, because I think the problem is everybody is on his full nerves, on the toes.
Finally, saving the
Yes.
patient is the criteria.
Saving the patient, and thought process may not be in the correct line. Unless you have a big team where other people take over when there is a complication and they think, and the operator who face the primary operator who produced or rather the unfortunate complication which has occurred due to the primary operator, he may have difficulty in thinking. So the other person who is fresh can come in and think better.
Yeah, on that background, I would strongly feel that Kaustubh, you did a great job.
Thank you.
Great
Yeah,
job.
I mean, single operator, managing a nurse and a technician on your right, and taking all the decision, do an echo, do a pericardial tapping, continue to work on the RCA. I think it was a huge effort. You know, many people would get nervous, and probably they would have put a covered stent and stopped, not even tried to wire
Open the wire.
Absolutely.
I mean, that's reasonable. Jabir or Srinivas, if this in fact was to be 5-year-old, are there times when you leave it and just concentrate on the left lesions and correct them?
Yes.
But here, perforation has happened, no, sir. Something has to be done for that.
No. I'm saying that ignore
leave about right and just think of left.
Ignore the right and just do the left.
Yes.
Especially there are situations, see, 5 years back, he had this problem. Later on, he was asymptomatic and a recent onset symptom, which for sure that it is likely to be the left-sided disease. We'll go ahead with the left side and forget about the right side.
I mean, he has lived 5 years with the right occlusion. So leave it. So don't compete with the surgeons.
Yeah.
I mean, they want to do all. So,
but many times surgeons will leave smaller vessels, sir. They won't graft.
No.
OEMs and all, we write to graft, but many of the times thinner vessels are not grafted. Some good surgeons are there, they graft everything. But many of the times we write grafting to PDA and OEM, they may not do it also. That both ways it is there.
I have in fact stopped writing. Because you don't know whether you are, I mean, they would get operated in your hospital or go to somewhere else.
Yeah.
So we just write CABG or whatever vessel you want to.
I think most of us are now like that only. Right, advise coronary artery bypass grafting. Then it is the surgeon who decides on which all vessels to be grafted.
Hiramat sir, so there is no surgery.
I thought they say this only in Ruby Hall.
I think the surgeon may be starving.
Okay, I think good cases, sir. I think it's 9:30. Thank you.
Dr. Onkar, congratulations for bringing another set of very exciting cases. And congratulations to all the presenters. We actually had a surgeon today presenting. So that is even more interesting. So, Dr. Onkar, think of widening the spectrum and maybe for next meeting, invite some surgeons also. And we will tell Dr. Jabir to present his multivessels, which he has taken away from the surgeon. And
now the problem is, sir, we are getting the aftermath of the surgeon's work. Look, surgery done 15 years or 16 years back. Now the graft gets occluded. We are trying to treat the native vessel, taking 3 hours, 4 hours, using all IVL, rotas, and all the difficulties of that thing. The patient survives because of good surgery, but later they come with problems after 15 years or 20 years. Now, I think some 5 to 10% of your work is that cases, isn't it, Dr. Srinivas?
Yes.
Yeah, actually, initially, when they started doing surgeries, 10-year, 12-year was a good period. And somebody lived 10, 15 years, did good job, worked in the office. We used to say very good results, very good benefit from surgery. But today, somebody gets operated at 65, is only about 75, 78 when some grafts go. And then comes the wisdom whether to manage the case with medical treatment or to go with an angioplasty, or to go for a repeat bypass surgery. Having said this, what number of second or a redo bypass we used to do 10 years back and what we do today, the number is exactly down by 50%. That means a repeat surgery is not happening.
Repeat surgery is quite rare nowadays because
first surgery also decreased, no, so significantly.
Surgeons are also very happy, you know, because repeat surgery is a mess.
Yes.
I know sometimes the surgeon has struggled for about 2 hours just to reach the heart. There were so many adhesions through which he has to go. So they also don't like it. And if we can manage with angioplasty, in fact, they would try and push this case should go to cath lab.
And now I think for the interventional cardiologists, their gadgets have improved much over the last decade. So we have now the IVL, ROTA, everything. So we are well equipped to deal with these situations.
Cost constraint should not be there. But only thing is, when you're dealing with such complex cases, cost constraint should not be there. You should not have that stress on your brain. And I always keep telling this, if that is not there, then you can do a good job. And finally, you might need an extra balloon, extra stent, wire. Cost issue should not be there. Hiramat sir, one dictum or one whatever logo or whatever you can, whatever theme you can say, no surgery before patient's active life is over, because before he retires, no surgery is wasting his precious time, family gets affected, 3 months leave and all that. So probably you say after 70, again, risk of surgery increases. So window is only narrow now for from 60 to 70 years, or maybe 58 to say 70 years.
No, mine is no surgery till 65.
No surgery till 65. That's what I'm saying. Before retirement, no surgery. You can stretch it to 65. And the only 65 to 70 is you narrowed it to 5 years or 10 years. Because after 70, surgeon feels is high risk again. Anyway.
No. I mean, let them struggle. Let them set it out in the theater. I mean, why should we get trouble all the time?
So 65 to 70 or 65 to 75? What is the window for surgery for you?
65 to 80. There are many people between 75 and 80 who are going for surgery.
But 75 years plus the pool fragile and all that is also trouble for them. So they keep requesting at this.
This was this thing in my mind also once upon a time. But these days, patients are taking so much effort to remain fit, exercise, correct food and all. So they would probably get to 75 without any trouble, and then they have multivascular.
Physically, they're fit, you're saying. Only chronological age, but biologically, they're like 65.
Yes.
Right. I think we can discuss for later. Thank you.
Thank you.
Yeah, Dr. Onkar, I think we must thank Emcure for bringing all of us together. Today, last time we missed one of you, Dr. Jabir.
I was not there. I got stuck in a case.
So Dr. Srinivas and I managed to continue, but 3 of us have been there almost every time.
But they have some plans to revamp and do it slightly different. They were telling Neha and Omkar. I thought we hear to them and then decide finally how about any change in the pattern.
I was suggesting that you should invite some surgeons, cardiac surgeons, to join the meeting. Many times cardiologist takes great interest in what they do in surgery because he has to handle them post-surgery. While the surgeon is not bothered, he would do what he wants, and follow-up is not with them. Follow-up is with cardiologists. So we are the ones who face problems if it is not done properly or it's an incomplete surgery. So patient is more connected with the cardiologist compared to surgeon.
Yes. Okay, we'll think and discuss further. Thank you.
Thank you, sir. So I thank our course director, Dr. M.S. Hiramat, sir. I also thank our moderator, Dr. Srinivas Kumar, sir, and Dr. Jabir, sir. I thank all our speakers for tonight, Dr. Kaustubh, Dr. Shravan, and Dr. Samir. So with this note, we'll stop here. Thank you very much for your active participation and bringing a lot of discussion points today night. Thank you. Thank you very much.
Thank you, sir.
Thank you. Good night, everybody.
Good night.
Thank you. Thank you. Good night.
Thank you, sir. Good night.
Recording stopped.